recurrent hernias require a little bit of special consideration because they represent a difficult problem on several fronts. For one thing, it's a pretty frustrating problem to have undergone surgery and had a hernia fixed, undergone a surgical recovery, only to find that the hernia has recurred. Often associated with the recurrence is pain and some frustration, and also the sense that there may be another operation to come which brings along with it a little bit more pain and some additional recovery time, perhaps missed work and time away from family. So there are a lot of considerations. Over the years, surgeons with an emphasis in hernia repair have learned how to reduce the chance of recurrence from day one. We as a field have gotten much better at creating hernia repairs that are more durable, long-lasting, and in most cases do last a lifetime. But still, today, no matter what technique is chosen, there is a rate at which hernias do recur, an annual rate over one's lifetime. Hernias can recur a bit more often with some older techniques. They can also occur more often if a person is very overweight or has an occupation or activities that involve a lot of lifting and straining with more stress and wear and tear on that repair. But even sometimes if there isn't any special wear and tear or stress or weightlifting or other factors, a hernia can still tear loose and recur and need to have surgery again. So there are some special considerations for the surgeon in approaching a recurrent hernia. In most cases, a recurrent hernia is best repaired with a technique that is somewhat different than the original repair technique. Let's start, for example, with inguinal hernias. Inguinal or groin hernias are the most common hernias, and they tend to be the most common recurrent hernias as well. Typically, a hernia that has recurred has been done with an open or conventional approach with an incision. And the best approach to repair that recurrent hernia is almost always a laparoscopic approach. I generally use a laparoscopic preperitoneal approach with a new piece of mesh placed behind the muscle rather than in front of it or on top of it, as is done with the open technique. This has several advantages. One advantage is that there's less pain and suffering, less swelling, and less recovery time associated with the laparoscopic repair. Additionally, I as a surgeon am not fighting through the scar tissue of the old open repair. Instead, I'm working in a new fresh plane and can easily work in that space and achieve a nice repair and a good understanding of the anatomy without having to fight through some difficult scar tissue. All of this leads to a better repair, a more effective and durable repair, and a better result for you. Other types of hernias can also recur. These include ventral and incisional hernias. Incisional hernias refer to bulges that occur in the scar of an old incision, and these are perhaps some of the most challenging hernias to repair. Once again, most of the recurrent incisional hernias that I see have been previously repaired using an open or conventional technique that involved an open incision and an attempt to pull the muscles together and repair with mesh, or sometimes without mesh. Typically, the best repair that can be done at that stage is to do a laparoscopic or minimally invasive repair. Once again, instead of fighting through the old scar tissue, as a surgeon I can move to the outside and approach it with a laparoscopic minimally invasive technique from within the abdomen and place our mesh material on the inside instead of going through the old scar tissue planes. Usually the visibility is quite good, and in fact it's excellent with this technique, and I can really see the borders of the fascia or the hernia itself and achieve a very good, very solid, durable repair. We place some anchoring, or what are called transfascial sutures, that go all the way through the abdominal wall that really anchor the mesh in position, usually at all four corners, a so-called north, south, east, and west anchoring transfascial suture repair, in addition to some dissolvable sutures called tacks, which are placed to secure the mesh to the abdominal wall musculature. Nowadays, the best repairs are performed using more modern mesh materials that are bilaminar, meaning that they have two materials that are put together. One is a traditional mesh material, but the other is a layer of material that prevents adhesions forming. So it prevents the intestines or the underlying organs from adhering or sticking to the mesh. And this is important because it minimizes the chance of scar tissue, which could be painful, but also the risk of it rubbing or eroding against those structures. So each hernia is a little bit different. There are exceptions to every rule, and sometimes, even though I specialize in minimally invasive hernia repairs and have advanced the field in minimally invasive surgical repairs, there are times when I recommend an open repair. That's not the majority of cases, but there are cases that I see in which an open repair will serve the patient best. So the important thing is to get a very qualified opinion from somebody who has seen a lot of different types of hernias and who's familiar with the most modern, most advanced hernia repairs, particularly the least invasive, minimally invasive hernia repair techniques. That way, I think you're armed with the best information about how best to go about repairing this hernia once and for all. Ideally, this next repair that you undergo should be the very last one. Ideally, it's the one that's going to last a lifetime and give you the best possible long-term outcome.